I'm presenting data this year at CROI from a study we're working on looking at aspirin use in HIV patients from a group of patients in Boston. As you can hear, there's a lot of accumulating evidence that HIV patients have higher rates of cardiovascular disease, including myocardial infarction or heart attack. And the underlying reasons for these higher rates are receiving a lot of ongoing attention, as you can see, and are being studied and include areas such as immune activation. In non-HIV patients, there's strong evidence that aspirin protects against a first heart attack and repeat heart attacks. And we looked at two separate things. We looked at whether HIV patients use aspirin in the same way that non-HIV patients use aspirin. And we found that aspirin use is lower in HIV patients. And interestingly, we found that aspirin use is particularly lower in HIV patients who are at the highest risk of heart attack, meaning they have multiple risk factors for MI. And this might speak to the lack of emphasis on chronic disease complications by HIV providers, or a perceived lack of risk by providers. And also notably, there's no particular guidelines on aspirin use for HIV patients. In an extension of this study, we looked at whether aspirin has any association with MI in HIV patients. So we had a group of HIV patients and non-HIV patients. As expected, among the non-HIV patients, the rates of MI were lower in the aspirin users. However, we found that aspirin did not have the same effect, or that same protective effect, in HIV patients. So there was no relationship between aspirin use and MI among HIV patients. The type of study we undertook, which is an observational study or a cohort study, is provocative, but the question of whether aspirin protects against MI in HIV patients is really best answered by a clinical trial. I think overall the study of prevention in cardiovascular disease and myocardial infarction will become very important as the population of HIV patients in the US and worldwide ages.
Michael Smith, MedPage Today. My question is, you said two things. One is that people, HIV positive participants, or in people in your study, were not actually using aspirin, and then that they weren't having any effect. It wasn't having any effect. Is that a function, is one the function of the other?
No.
Or did you control for that in some way?
So we looked at the rates of use, but then we looked at the HIV patients and the non-patients who were actually using versus non-using. So we did look at the HIV patients and only studied the rates of MI among those who were using aspirin, and then the rates who were not using aspirin. So they weren't necessarily related.
And are those, same question, are those numbers the same as in the abstract?
They're the same as they are in the abstract. There's no update.
Do you have any explanation for that?
For which part? The underuse part?
The other part.
So yeah, I think that that's sort of the question that this study raises, is why there might not be that association seen in HIV patients. I do want to qualify and say that I'm not saying that HIV patients should not be using aspirin. I think that the data is provocative, but as I mentioned, probably merits a clinical trial. But I think it speaks to possibly some of the underlying differences in the pathophysiology and the underlying causes of coronary disease in HIV patients versus non. As you hear that there's a lot of emphasis on immune activation, and there also has been study on platelet activation and platelet aggregation, but perhaps in the HIV patients there's an altered role of this, which might explain the differing effect of aspirin, but I can't fully answer that question.
Hi, Miles Hoffman from thebody.com. Actually, this is a follow-up question to that. Did you see, was there a differential between the HIV positive patients and HIV negative patients who took the aspirin in terms of not their baseline MI risk, but the extent to which they might have already been, let's say, for instance, that the HIV positive patients maybe were a little bit more significantly progressed toward having some kind of event, and so maybe that would have accounted for the lesser effect?
Right. So we sort of looked at what are the baseline characteristics of the aspirin users versus non-users in both the HIV patients and the non-HIV patients. And in both the HIV infected and non-infected, the aspirin users were, as you might expect, they were sicker, and they had higher rates of dyslipidemia, hypertension, higher rates of smoking, but they had higher rates in both the kind of sort of similar higher rates in both the HIV patients and the HIV uninfected patients. And we attempted to control for those in the analysis, but there still might be sort of unmeasured confounders or things that we couldn't necessarily measure that might account for the difference.
So, Sujit, can I ask you a question? There's a difference between aspirin prescription and aspirin use. So, and these are patients on lots of medications. So one possibility is that they were prescribed it and they just didn't take it. Do you have any sort of feel for that?
Yeah, so I mean, it's hard to measure aspirin use because a lot of times people purchase it over the counter. So part of the study was that we developed an algorithm and a way to validate whether people were taking aspirin or not. So we did look at and saw that a lot of people were getting prescriptions of aspirin, but you're right to say that part of our what we looked at was basically the electronic medical record and seeing whether doctors indicated that the patient was taking aspirin. So there were indications that physicians were saying in their clinical notes that this patient is on aspirin, but you're right saying that I can't necessarily correlate that with adherence or compliance to aspirin. I'm not able to make that full assessment.